Today we are going to discuss the important topic of measuring quality. No doubt, whatever you do in health information technology, you will be producing reports about performance, either how people are doing, how your computer systems are doing, and what you want to do is make sure that those reports are accurate and as useful as possible. The objectives for this presentation are to understand the basic concepts of variation, explain the attributes of an effective reporting system, examine the importance of having standardized and structured health information so that you can use those data to make valid reports, and discuss how health information technology can facilitate data collection and reporting for improving quality of care and patient safety. Davis and colleagues performed a systematic review of the literature and determined that the preponderance of evidence suggests that physicians have a limited ability to accurately self-assess. There is similar evidence regarding other healthcare professionals. However, neither the act of measuring nor the resulting data accomplish this, according to Professor Ben. So why measure? Because we can use the data we get to understand our system better and improve it. Many factors impact overall data quality. This figure illustrates how different data features impact quality, such as how elements are defined, how data is collected, how data is processed, and how data is presented. What is critical, however, is how this figure demonstrates the interdependence between the utility of data and data quality. The usefulness of data analysis is totally dependent upon upstream factors related to data quality. The Institute of Medicine defines data quality as having data strong enough to support conclusions and interpretations equivalent to those derived from error-free data. There are different measures of data quality, such as reliability, validity, accuracy, completeness, and timeliness. Reliability and validity relate to whether or not the question and measurement are good representations of what is supposed to be measured. Accuracy relates to whether the data that are collected are correct. Completeness relates to whether all the data are collected and available, and timeliness is related to whether the data is still relevant given the time point of its use. Reliability relates to the stability or equivalence of repeated measurements of the same phenomena. Reliability can be measured through a correlation coefficient or a close statistical relative, for example, kappa coefficients, Cronbach's alpha, interclass correlations. Reliability can be measured on a scale. For example, it can be measured on a scale from 0 to 1, where 0 reflects the lowest possible reliability, that is, none, and 1 reflects perfect reproducibility or correspondence. Low reliability equates to high variability in measurement. Measures with low reliability are minimally useful. Highly reliable measures increase the statistical power for a given sample size, enabling statistical significance to be achieved with a smaller sample. The validity of a measure represents the degree of systematic differences between responses to outcomes relative to 1. The extent to which a measure adequately represents the concept of interest. This is known as content validity. 2. The extent to which an outcome predicts or agrees with the criterion indicator of the true value, a gold standard, of the concept of interest. This is known as criterion validity. And 3. The extent to which relationships between the outcome and other measures agree with relationships predicted by existing theories or hypotheses. And this is known as construct validity. Let's turn to an example of data quality. In the course of a clinical research study, data were entered one at a time at a local data center into a clinical data management system. During the analysis, the principal investigator noticed results for 2 questions that seemed unlikely. The data were reviewed against the original data collection forms, and it was discovered that on roughly half of the forms, the operator entering the data had transposed yes and no. We are surrounded by variation in our daily life. One day is colder than the next, even with the depths of winter. Sometimes the bus is on time and sometimes it isn't. How do we know if the changes in temperature are the result of random change or the result of an actual trend, for example, climate change? How do you know if the bus is just a couple minutes late or something happened to it? An essential component of data management and quality improvement is understanding variation. The concept of understanding variation emerged from the work of Deming, Schuhart, and others in the 1950s. There are different interpretations of variation and how you use it in decision making. One is to use variation to evaluate performance, and the other is to use it to understand the causes of change in a system. When you use variation to evaluate progress, the focus is on the outcome of the process, so as to classify outcomes as acceptable or not. The basis of the variation analysis is what the customer needs, and it uses a variety of methods to achieve this evaluation. On the other hand, the use of variation to understand the causes of change in a system provides a basis to take action on a process. It is not based on customer needs, but on what the process is actually delivering. It uses run charts as the main method to ascertain variation. In his work, Deming described two types of variation, the common cause variation and the special cause variation. In the common cause variation, a phenomenon happens on a regular basis within a given system. This variation is predictable and it happens within historical limits. With common cause variation, there is no real change in the system or our knowledge of it. Let's use the timeliness of buses as an example. Buses don't come at the exact same time every day. They show up some minutes in advance or delayed, depending on traffic and weather conditions. There is variation in the time of arrival, but it is always predictable, and it happens within historical parameters. This variation does not signify change in the system. Someone waiting in the bus stop would say, "Usual delay." In the special cause variation, a new phenomena is introduced into the system. The variation generated by this new element is unpredictable, and it happens outside of historical experience. It signifies the change within the system or our knowledge of it. Continuing our earlier example, imagine an accident that causes a 10-car pileup and blocks the main avenue for 3 hours. The delay caused by this accident would be a new phenomenon introduced into the system. It would be unpredictable beforehand, and the delay would be beyond the historical parameters. This variation occurs because there is a change that has been introduced into the system. Someone waiting in the bus stop would say, "Something must have happened." According to Perla, Pronovost, and Murray's manuscript on the use of run charts, there are a number of tools used for Schuhart or control charts and their various derivatives, such as cumulative summation charts and funnel plots. In order to simplify and make our process performance data easier to understand, a run chart is suggested as a method to reduce the computational complexity. For example, instead of using standard methods such as chi-square, an f-test, or t-test to compare differences in performance, using the time order in which data was collected can be quite helpful. Improvement activities that can be addressed with the run chart may include the following: making process performance visible by presenting the actual data, verify if improvement was achieved after implementation of changes, ascertain if the changes that were made were sustained, and finally, allowing for views of data that are real-time, temporal, and not static. Look at this graphic. There clearly has been a statistically significant improvement before and after the change. But what other information can you gather from this graph? Was the improvement due to the change? Is the improvement holding over time? It is very difficult with this type of graphic representation of data to determine what happened over time and to get a good understanding of what is happening to the system. Here's an example of the power of using run charts. The 3 line charts on the right reflect data in the histogram on the left. Taken together, the data represented on the right have a pre-change average of 70 and a post-change average of 30. However, as you examine the display of the outcome over time, you will realize they tell very different stories. In the blue chart, you can see the outcome hovered around 70 before the change, and although there is 40-point range, the outcomes after the change hovered around 30. The change seems to have produced an improvement in the outcome. In the green chart, there is a progressive decrease of the value of the outcome that started before the implementation of the change. Although there seems to have been improvement, it's not due to the change implemented. Finally, in the maroon chart, there is an improvement after the change, but it seems to be short-lived since, after the March measure, the outcome seems to worsen again. In the previous slide, we have discussed the existence of improvements based on the visual display. There are, however, statistical rules that support the interpretation of run charts in a more objective manner. There are 3 objective rules that identify non-random patterns, with an alpha error of p less than 0.05, the shift, the trend, and the run. There is an additional subjective rule that is included to recognize the importance of the visual display of the data in a run chart, the astronomical point. The effective detection of expected delta or change in planned quality improvement projects requires the use of tried and true statistical measurements. These 4 measurements will be addressed on the next slide. A shift can be said to have occurred when 6 or more successive measurement points are either all above or all below the median. Values that fall on the median do not add to nor break a shift. You simply have to skip all values that fall on the median and continue counting. A trend occurs when 5 or more consecutive points all go up or all down. If the value of 2 or more successive points are the same, only count the first point and ignore the repeating values. Values that are the same do not make or break a trend. A run is a string of points all in a row on one side of the median. Counting the number of runs is easy. Simply count the number of times that the line connecting the data points crosses the median line, and then add 1. An astronomical point is one that is an obvious and marked outlier. This means that everyone who studies the chart would agree that the point is out of line and unusual. This is the graphical representation of a shift. This time series has 2 shifts. The first one presents 11 consecutive points above the median. The second shift represents 14 consecutive points below the median. The same chart contains 2 trends. The first one has 7 consecutive points all going down, and the second one has 11 points going down. The green arrows in the chart point to the runs where the time series crosses the median. After having reviewed the shifts, trends, and runs, you can now state with a p is less than 0.005 confidence what you had suspected by simple inspection. There is an improvement in the process that is being analyzed. There is one last thing you must do. Inspect the chart looking for astronomical points. Although this is, as has been mentioned, a subjective rule, it does give an idea of where things are going. In this case, the outcome or measure is improving and the presence of the astronomical point is in the same direction of the improvement. Although the presence of the astronomical point in the middle of the timeline makes you wonder what happened to the system to induce such a change that was not persistent over time. Astronomical points help you devise these types of questions. The variation can be assessed in a variety of measures. As discussed in a previous unit, the measures we utilize in quality improvement are divided into 3 types. Process measures, which are ways to examine the steps in a system and determine if a system is performing as desired. Performance measures will improve before the outcome measures do. They assist us to determine if we are on track to get the improvements we wish to see in our system. Outcome measures are ways to determine the impact of changes made to a system. Outcome measures quantify results from the view of patients, their health and well-being. There are also ways to track the impact on other stakeholders such as payers, employees, or the community. And then balancing measures, which are designed to give a look at the whole system and make sure changes are not causing new problems in other parts of the system while trying to fix it. Although these measures tend to gather data based on cost or patient experience, any of the process or outcome measures could be used as balancing measures if users get a better look at the system. As electronic health records are made, an important component is the design of data fields that can be used to generate reports and understand the variation in the system. These data fields are better suited for data management if they exist as structured data fields and not as free text. Although reports can be generated from free text fields, the lack of standardization makes their interpretation quite challenging. The use of structured data fields should be encouraged wherever possible. In a number of quality improvement projects, teams are limited by the quality of the data. Teams need to decide what the source of the data will be and where in the EHR the data required will reside. After doing so, all individuals involved in the process ought to be trained in the proper data entry procedure to ensure a high quality of data. Most electronic health records come out of the box with a number of, quote, canned reports. These are generally used across a variety of settings and don't require any update or customization of the reporting solution. For any additional data needs, there are a number of commercial solutions that can generate reports directly from the electronic health record or that enhance the EHR solutions. Recently, the Office of the National Coordinator funded Pop Health, an open source reference implementation software service that automates the reporting of meaningful use quality measures. Using continuity of care records, known as CCRs, Pop Health is striving to integrate with the healthcare provider's electronic health record system. Here are some useful tips to improve the general quality of data. First is to structure data entry or data collection forms whenever possible. Ensure those who are entering data are crystal clear about who, what, where, when, and how. That is, if you are calling something infection, make sure that those who are labeling it know what the definitions are, when they are supposed to enter the data, and how they actually enter the data into the HIT so that we get much more valid data. Next point is pilot test whenever you can. And really pilot test every phase of the process, from writing the definition to having the staff enter the data, to producing the reports. It is a good opportunity to pick up mistakes or things that aren't clear when you pilot test. However, in many quality improvement projects, comprehensive piloting is not possible. It is important to formally train and evaluate the competency of those entering the data. Ideally, formal training includes evaluation of performance and the provision of feedback. Next, consider the evaluation of data quality. There are 3 simple data checks that will pick up over 95% of data problems. First, look for missing data. Determine the reason for the missing data and correct it if possible. Second, look at your outliers. And the last common data quality check is looking for repeat values, especially for denominators. In summary, measurement is an essential component of quality improvement. Understanding variation provides a context to interpret the data we collect by allowing us to determine if there has been a change introduced to the system or it is random variation we are detecting. Run charts are a simple statistical methodology to interpret the data collected. And health information technology has an important role to play in any measurement strategy.